Good morning to all. Today's topic is about Pediatric TEE series, discussing about single ventricle. Introduction. Single ventricle is also called as univentricular heart. Normally, the heart has four chambers. Left side are the LA and LV, and right side will be the RA and RV. Whereas in this case, a single ventricle, one ventricular chamber is rudimentary or absent, and therefore it is unable to function as an independent separate chamber. So, from a surgical point of view, the use of the term single ventricle has been expanded to include all manner of cardiac lesions in which a biventricular intracardiac repair cannot be performed or may not be considered the optimal approach to separate the both systemic and pulmonary circulations. In the management of the single ventricle patient, the ultimate goal is to separate the systemic and pulmonary circulations. Here, since the one of the ventricle is non-functional, there is due to the lack of the second functional ventricular chamber which can deliver the blood to the pulmonary arterial bed, the systemic and pulmonary circulations must be separated so that the deoxygenated systemic venous blood returns passively to the pulmonary arteries without the assistance of the separate pumping chamber. So the resultant physiology is also called as known as spontan physiology. It forms the basis for the current management of the single ventricle patient. Application of the TE for a single ventricle in intraoperatively to verify the anatomy and physiology in the preoperative aspect, whereas in the postoperatively to evaluate the results of cardiac surgery. In the adolescent or adult patient with a complex single ventricle anatomy, TE can serve as a supplemental tool for diagnostic evaluation. Postoperative Fontan patients having marginal to poor transthoracic echo windows, and in this setting, TE can be used for improved evaluation. Coming to the various anatomical types of single ventricular, hypoplastic left heart syndrome, hypoplastic right heart syndrome, tricuspid atresia, and univentricular atrioventricular connection. And now coming to the hypoplastic left heart syndrome, it is lesion characterized by varying degree of left-sided hypoplasia. This classic cardiac defects in this category includes mitral stenosis, mitral atresia, aortic valve atresia, and diminutive left ventricle. There is markedly hypoplastic ascending aorta and aortic arch and aortic isthmus with the posterior aortic shell, also called as coarctation. The defining characteristic of this hyperplasia left heart syndrome includes inability of the left-sided structures to independently support the systemic circulation. The RV assumes the left-sided hypoplasia. The RV assumes a primary role as the systemic pumping chamber, providing blood to the systemic circulation via forward flow through the main pulmonary artery and the patent ductus arteriosus. The TE evaluation of this hypoplastic left heart syndrome, the most common initial view performed is midesophageal 4-chamber view at 0 degree. The specific TE evaluation should focus on include the systemic and pulmonary venous return, to rule out any atrial septal patency, and to look out for the tricuspid anatomy and the regurgitation if at all present. Also, we should look out the RV morphology, function, and any regional or motion abnormalities and the pulmonary valve function. In the mitral aortic valves patent, the flow across can be evaluated. The coronary artery origins can be viewed from the modified midesophageal aortic short axis view with anti-flexion 0 degree 45 degree. Other intracardiac anomalies associated with hypoplastic left heart syndrome such as anomalous pulmonary venous return and SVC to a dilated coronary sinus can also be seen by TE using the midesophageal views. The hypoplastic ascending aorta in the midesophageal long axis view or midesophageal aortic long axis view at an angle of 80 to 90 degree. In this view, you can measure the accurate ascending aortic diameter. Also, ductal patency and color flow Doppler in the upper esophageal aortic arch short axis view and upper esophageal pulmonary view. There will usually be low velocity right to left ductal shunting in systole and left to right ductal shunting in diastole. If HLHS is associated with very small or absent atrial communication, a small decompressing vein connecting the left atrium or pulmonary vein to innominate vein is also called as levoatrial caudinal vein. This serves as an alternate pathway to reroute the pulmonary venous blood back to the right heart. This view is usually seen at upper esophageal arch ascending aorta short axis view on upper esophageal pulmonary views, using left-toe rotation to demonstrate the vein as it returns to innominate vein. This is a TE view imaging showing the hypoplastic left heart syndrome. In this first picture, there is a midesophageal 4-chamber view is showing a single mitral narrowing at the mitral valve, causing mitral stenosis and as an underdeveloped left ventricle hypoplasia. Whereas the second diagram it shows the atrial septum, which is interrogated by the color flow Doppler. And this TE image showing the midesophageal long axis view, there is an aortic valve there is a diminutive ascending aorta and a proximal ascending aorta, very small underdeveloped ascending aorta. This forms the basis of the hyperplastic syndrome. Next, coming to a category called hyperplastic right heart syndrome. This spectrum of cardiac lesions is characterized by pulmonary atresia. It can be either a formed pulmonary valve but imperforate, also known as membranous atresia, or a long segment muscular atresia in which no pulmonary valve is present. There is a varying degree of RV hypoplasia and an intact ventricular septum. This class is referred to as pulmonary atresia with intact ventricular septum. It is a rare cardiac abnormality. The TE evaluation of this hyperplastic right heart syndrome, it focuses on the adequacy of the intra-atrial communication as well as the degree of tricuspid valve and RV hypoplasia. The atrial septum is formed from can be viewed from the mid-vesicular fourth chamber and mid-vesicular bicameral views, and a tricuspid and hypoplastic RV are best seen at the mid-vesicular fourth chamber view and mid-vesicular RV in outflow views. The left ventricle and mitral valve function can be evaluated by using mid-vesicular fourth chamber view, mid-vesicular two chamber view, and mid-vesicular mitral and mid-vesicular long axis views. Additional information regarding the LV and mitral valve functions by the transgastric basal short axis view, transgastric mid-papillary short axis view, and transgastric long axis views. This is a TE image showing a hypoplastic, a very small muscular or non-apex forming right ventricle. At the most commonly at the mid-vesicular fourth chamber view can be best seen. Here the RV very small, RV can be very small and muscular, and it is not apex forming. And in this modified mid-vesicular right ventricular inflow-outflow view, there is a trabecular portion of the RVs underdeveloped in the first diagram, and in the second diagram there is a significant TR is there as shown in the colorful Doppler, and there is a presence of imperfect pulmonary valve without antegrade flow. The pulmonary valve is very underdeveloped. Next, coming to a category called tricuspid atresia, is also called as in this category there is no functional tricuspid valve. There is complete absence of any valvular tissue with only a muscular shelf seen in the tricuspidal position. In some instances, the tricuspid valve is formed and present but imperforate, so called membranous tricuspid atresia. In either case, there is obligate right to left shunting across the atrial septum and complete mixing of deoxygenated and oxygenated blood at the atrial level. A small RV cavity with marked hypoplasia of the inflow portion but variable trabecular and infundibular portions, and usually a communication exists between the LV and hypoplastic RV. This communication is termed a ventricular septal defect, also called as outlet foramen or bulboventricular foramen. It is located between the left ventricle and the infundibular portion, but also close to the apex of the small RV, and it is always surrounded by muscular rim. This tricuspid atresia is one of the most common forms of the cyanotic congenital heart disease. Incidence is approximately 12 per 1 lakh live births. It constitutes about 1% of all congenital heart disease. It is most recognized classification for tricuspid atresia is based upon the relationship of the great arteries. Next, coming to the classification of tricuspid atresia, type 1 is the normal rated great arteries. It constitutes about 70 to 80%. Type 1A, there is intact ventricular septum with pulmonary atresia. 1B is small ventricular septal defect and pulmonary stenosis. Type 1C is large VSD and no pulmonary stenosis. Next comes to type 2 TGA, with it constitutes about 10 to 25%. Type 2A is VSD with pulmonary atresia. Type 2B is VSD with pulmonary stenosis. Type 3C is VSD with no pulmonary stenosis. And type 3 is tricuspid atresia with transposition or malposition of the great arteries. It constitutes about less than 10%. In this category, the associated complex lesions include LTGA, DORV or DOLV. And also the tricuspid atresia can also be included. Type 1 and type 2 tricuspid atresia are the most common form of tricuspid atresia, whereas type 3 is much rare. It constitutes about less than 10% of the patients. Coming to the TE evaluation of tricuspid atresia, evaluation from the level of medius vagus, particularly using the medius vagus fourth chamber view for evaluation of the atrial septum, medius mitral valve, left ventricle and great arteries, as well as the ventricular septal defect. The supplemental evaluation can also be used by other mid-vesicular views, mainly the mid-vesicular bicameral views for the systemic venous return, atrial septum, mid-vesicular long axis views for the mitral valves, semilunar valves, for the VSD, and mid-vesicular RV inflow view to look out for the VSD, and deep transgastric 5-chamber view, deep transgastric RV view for the good visualization of the mitral valve and VSD, as well as aortic and pulmonary outflow tracts. Deep transgastric views can also be used for spectral evaluation of the outflow tracts. This TE image showing the tricuspid atresia with category 1 with which is non-related great arteries. In this mid-sphincter fourth chamber view, right side we can see the lack of visible tricuspid valve. Only a muscular shelf is present as well as the RV is chamber very hypoplastic. And the second diagram, there is small VSD is present with the turbulent left to right shunting can be viewed by color flow Doppler. Coming to the next image, TE image of the tricuspid atresia with DTGA. In this mid-sphincter long axis view at angle of 9 to 120 degree, it shows the origin of the pulmonary arteries arising from the LV and aorta arising in a small anterior RV chamber. This is a color flow diagram showing very small anterior RV chamber. Next, coming to the last category is called as univentricular atrioventricular connections. This category of single ventricle defect in which both atria empty completely or almost completely into one large ventricle. In this, the second ventricle might or might not be present. If present, it is generally quite hypoplastic. This group of defects includes unbalanced AV atrioventricular septal defect, double inlet left ventricle as well as rare double inlet right ventricle. The true single or solitary ventricular chamber of intraventricular morphology also comes under univentricular atrioventricular connection. Coming to the TE evaluation of the unbalanced atrioventricular septal defect, the particular attention should be paid to the degree of the common atrioventricular valve distribution or concomitant to the underlying ventricular chamber ventricular hyperplasia, and also to look for any possible aortic or pulmonary outflow tract obstruction. A combination of the mid-sphincter fourth chamber view, mid-sphincter two chamber view, mid-sphincter long axis view are best for evaluating the common atrioventricular valve and ventricular chambers and also the degree of atrioventricular valve regurgitation. The deep transgastric 5 chamber view, deep transgastric RUAT can also be used to evaluate the atrioventricular valve. In this TE image, there is showing the unbalanced atrioventricular septal defect, most commonly performed at the mid-sphincter fourth chamber view at 0 degree. In this first diagram, it shows the extremely right dominant or right ventricle with atrioventricular septal defect and very small underdominant left ventricle. The large common AV valve empties almost completely into the right ventricle. In this second diagram, there is a large common AV valve empties almost completely into large right ventricle, and there is a colorful Doppler showing segment central aortic valve regurgitation. Next, coming to the category of double inlet left ventricle. This double inlet left ventricle typically have two separate atrium, each has its own AV valve. Both AV valve empties into a large ventricle of LV morphology and there is generally a smaller RV outflow chamber located anteriorly. In most cases of DLV, it is very difficult to determine which AV valve is tricuspid and which is mitral. So, the three general categories of DALV are nominated great arteries, DTGA and LTGA. In a patient with DALV and NRGA, also called as Holmes heart, it is normal aortic valve and aorta arising the large LV with pulmonary or RV outflow chamber with varying degree of subpulmonary stenosis. DLV with LTGA is the most frequent, contributing about 38%, followed by DTGA forms 25%, and DALV and NRGA being the least common of the three. In both forms of DALV TGAs, there can be significant subaortic narrowing, often with ascending aorta or aortic arch hyperplasia, or subpulmonary narrowing depending on the size of the VSD and portion of the infundibulous septum. In this TE image showing the double inlet left ventricle with normal rated great arteries. In the first diagram showing the mid-sphincter fourth chamber view to visualize both atrioventricular valve, and the second TE shows image at the modified mid-RV inflow with 30 degree with probe antiflexion shows origin of the PA from the hypoplastic RV. In this TE image showing double outer right ventricle. In this most performed first diagram is a mid-sphincter fourth chamber view. Here you can see the both right and left valve drain into the RV, inserting into a large bizarre RV papillary muscle. There is a left-sided hypoplastic left-sided LV. And the second TE image shows mid-sphincter long axis view at around 9 to 120 degree is showing the both great arteries, that is aorta and pulmonary artery seen to arise from the RV with aorta seeing anterior to pulmonary artery. Thank you.